another advance in ALL, and I think in hematology, is CAR T cells. Where you see the role of CAR T cells today? Bridging for transplant, finite therapy, or replacing allotransplant?
I think I see it most as a bridging and as a replacement of transplant early on when it is used. I mean, I think for transplant-naive patients, we still can advocate to transplant these patients if they're fit, if they have good donors. I think we need to see more data about long-term outcomes and larger actually cohorts that showing that really transplant doesn't help these patients in the relapse refractory setting. But again, it is my usually first choice treatment for someone who relapses after allotransplant, or second transplant usually it is not feasible.
We've seen from the ZUMA-3 trial, the transplant-related mortality is at 25%. In a ZUMA-3 trial, means you get Brexucel and you go for transplant and you have still quite a high mortality. Yes, you may tell me I want to cure you at the long run, but I have to pay a very heavy price for it.
Yeah. No, I agree. I mean, there is a high treatment-related mortality, but actually, I mean, we're seeing some data from real-world data for Brexucel that actually transplant appears to be beneficial in transplant-naive patients. And maybe Aaron can comment more. He's part of these efforts.
I want to ask you, Aaron, you mentioned the serial monitoring post-treatment, correct? So here, if we give CAR T cells, be it Brexucel or obe-cel, and you have a serial monitoring, can you say, I want to omit or put transplant on hold for now and see how it goes?
I think that's an essential question that all of us are asking as we're treating patients. In the ROCKET Consortium, we have done an analysis looking at patients with relapsed refractory ALL who achieved an NGS negative remission with Brexucel. And it does appear, as Ibrahim has mentioned, that there's still a benefit to receiving a consolidative allotransplant in the real world. And I think there may be some significant differences between who went to study on ZUMA-3 versus who we're treating in the real world. By doing these studies, all of us have learned how to manage and utilize CAR T cells better, implementing them earlier on, and utilizing transplant earlier on. If you do a transplant in the second and third remission, you're going to have a worse outcome, including higher relapse mortality and non-relapse mortality than if you do a transplant in the first remission. So I do think that we've learned a lot, and these studies are still suggesting right now that there's a benefit to consolidative allo, except for those that are receiving CAR T cells in a post-allo setting. So if they're already allotransplanted, we really should not be seeking a second allotransplant in those patients because there appears to be benefit to CAR T cells with an allogeneic immune system. And those patients actually do better than patients who never got transplanted.
You know, in Houston, we're seeing less and less relapses. In fact, with the Blina being upfront, inotuzumab as well, we don't see any more the relapses we used to see before. And we've seen all the data showing survival of 80-90%. Now, we know as well from the CAR T experience that early use of CAR T is more beneficial than waiting for multiple relapses. Therefore, in our practice today, and my practice, we have integrated CAR T in a first salvage. This is your case in California, being in Los Angeles or San Francisco, using CAR T in a first salvage?
I mean, first salvage, yes, definitely. I mean, there's an advantage of CAR over other therapies. I mean, there are some settings for MRD relapse where you can give blinatumomab, take the patient to transplant if that's the goal of that. But yes, I mean, there is more advantage of CAR over other therapy.
Okay. And tell me about your excitement for the novel drugs. Sub-Q Blina, bispecific, we know AstraZeneca have one, as well as Merck have another one. Where do you see the field evolving? Or maybe CD22 or dual, whatever, CD19, CD22?
Yeah, so I'm excited about this new generation of bispecific antibody. I mean, the data looks very encouraging for the AZD0486, for the Sub-Q Blina, in terms of the potency as well as maybe more convenient to give it than the continuous blinatumomab. And the way I see it, I mean, most likely this will replace the continuous IV blinatumomab, and it will actually improve the outcomes of the frontline therapy furthermore. Now, beyond CD19 therapy, I mean, we're looking for other kind of target therapy, especially as we're using more CD19 target therapy in the frontline setting, we're going to end up with more patients failing CD19 and frequently having CD19 negative relapse where we need new targets to kind of attack.
Aaron, do you encounter CD19 escape post-immune therapy, not the CAR Ts, and what has been your strategy for these patients?
Well, I think fortunately with blinatumomab, we don't see a lot of CD19 antigen loss. Of course, we see it more frequently with CAR T cells. But for patients who have lost CD19 expression, I do think it's a difficult scenario because we really only have one immunotherapy tool available commercially, which is inotuzumab ozogamicin. I think all of us would love to have a CD22-directed CAR T cell or some other antigen-directed CAR T cell available for the CD19 antigen escape patients. But right now, it would be inotuzumab, transplant them as quickly as feasible, because if you don't capture the disease, you're going to lose control of it.
You know, before we conclude, ALL is very rare. With 6,000 cases of ALL in the USA, adults are less than half of them. So, and then we know clearly that patient handled in academia and center of expertise and excellence, they do much better than in community. How are you doing to foster a relationship with the referring physicians, create awareness, or manage your collaboration with them? Aaron?
Well, I do think that this is essential, especially as these treatment programs are quite long. So we try and partner with our referral base so that patients can come to us to have a consultation. We can guide their therapy. For most of these patients, we are administering the blinatumomab, although we're trying to help many of our referral network feel more comfortable administering blinatumomab. I do think that subcutaneous blinatumomab may make this a lot easier and be able to implement community administration of blin. But that partnership is essential so that the academic physician can guide the best decision and time points for changes of therapy, escalation or de-escalation, including transplant, so we can achieve the best outcomes.
Thank you. And before I conclude, any last word you want to share with me?
No, I agree with Aaron. I think there's a benefit for ALL patient to be referred to academic centers, because initial diagnostic is very important to better stratify the patient. And it's getting very complicated how to treat ALL with the incorporation of immune therapy and when to kind of decide about transplant or not. Yeah, but it is an exciting time for ALL with all the new immune therapy. We're able to kind of cure more patients, able to stratify who need to go to transplant.
That's amazing. I feel we're very fortunate to live in a time where making impact on the life of people, saving life. And I hope that what we do in our practice today will become standard of care worldwide. So every human being, whether they're in Africa or in Asia or in USA, will have access to the best care possible to cure this disease once and forever in our lifetime. Thank you so much for being here today. Thank you.